Noon, February 19th, and we're continuing with organizations, advocates around budget. And next we have Jessica Barquist, Planned Parenthood. Thanks for joining us, Jessica.
Yeah, thank you so much for having me. Hello, Jessica Barquist. I'm the Vice President of Public Affairs for Planned Parenthood of Northern New England. We serve nearly 16,000 patients and over 23,000 visits at our 7 centers and telehealth last year. And 54% of our patients have low income. Last year, we provided 1.3 million in free and low cost care, which is a significant increase from 802,000 the year before. And it seems important to note that many of our patients tell us we are their only health provider that they see all year. We are a safety net provider for patients who are struggling the most. Not only is our care affordable, it is highly rated. In our most recent after visit surveys, patients gave us an overall score of 97.5 out of 100 for likelihood to recommend. And as you've heard from all of my colleagues in the healthcare system, and you know well, our ability to continue offering this high quality, affordable care is in dire jeopardy. A significantly broken healthcare system coupled with endless political attacks at the national level has left Planned Parenthood of Northern New England with a funding gap of more than 8.6 million over the next 3 years. Despite our internal efforts to achieve financial stability, this budget crisis could get much worse with the Trump administration, which has already promised to slash our funding and remove us from programs that serve low-income Vermonters. So we have 2 requests for you today, and both of which are relatively modest, recognizing the extreme need of our entire healthcare system, but also things that would really maximize our ability to keep all of our healthcare centers open in the state, which as a little bit of an aside, in 2022, when you all were doing really great work to codify abortion and gender affirming care into our reproductive liberty and our Constitution, not gender affirming care is not in the Constitution, but reproductive liberty is. And in that same year, as every Vermont town overwhelmingly supported that amendment, we closed 4 health centers across the state. And those communities, anytime I'm in them, are still telling me about the devastating impacts that those closures have had on those communities. So our goal with these budget requests is to not have to close any more of our health centers across the state, because we know that the impact that it has on community health and well-being. That being said, our first request is not just for Planned Parenthood, but I can only calculate the numbers for Planned Parenthood because that's what I have access to. So we would probably need some DVHA help to figure out what it would mean. But we are asking for a family planning Medicaid rate increase. Medicaid provides an enhanced federal match of 90-10 for family planning services, meaning that whatever the state invests in family planning, and that's contraceptive services, the federal government would cover 90% of that increased rate. And so we, and I submitted a chart. It's really hard to read on paper. I did print it for you all, but it's very small. But it is also, I submitted it to Kristen, what those rate increases could look like for the top family planning codes. And this is based off of work that Maine did a few years ago. So we estimate that a modest state investment of $85,000, leveraging this 9-to-1 federal match, would unlock $850,000 in additional funding for family planning patients in Vermont.
I'm looking at your little teeny tiny.
I know, it's so tiny. I'm so sorry.
You can open it or on my iPad. So
Oh, it's 85. And then it gets matched with 700 something.
That's right. Yeah.
So I'm just looking at this chart, and are these the particular codes that you're looking for rate increases on?
That's right.
So can I ask specifically? I mean, yes, a lot of this I can see as family planning. But you're asking for rate increases on all E and M codes, office visit codes as well, regardless of the reason, or is that tied to a diagnosis on those codes?
The full text of that code is cut off on my printed out copy, so I would have to get back to you on that.
I'm specifically, I'm just looking at from 99202 to 99215.
Yeah.
Which are just office evaluation and management.
Yeah, it looks like there's more under that service description that I can't see on my printed out copy.
Okay. If you could get the answer for me, if you're just looking for a general rate increase on that code, anytime that code's billed, or only if that code is tied to a family planning diagnosis code or some sort of reproductive health
Yeah,
diagnosis.
I will definitely get specifics for you. My understanding is that these codes are specific to family planning services.
Okay. Great, thank you.
Yeah.
But right there in the blue, it says for family planning services.
Okay.
Should I pause for questions on that before I move on to my next?
Any questions, anyone?
Okay, well, this would be a question for later. It's about the closures that you referred to. I don't know if you want to do that now or later, but I'm curious.
Well, we can do it now.
Yeah.
What happened?
Yeah, a similar financial crisis caused the affiliate to close centers that were unsustainable.
So under reimbursement led to unsustainable financial. Okay.
I just have so. The investment that you're asking for, the eight, is that like maxed? Like if you ask for 100, did you get 1,000,000? Why that number?
We base the rates off of the rate increases that other states in New England have done so that the rates are comparable across states. But yes, essentially. And, you know, while we are the largest family planning provider in the state, other providers use these codes too. So the 85 is just what we could calculate for Planned Parenthood. Diva would have to give you kind of the full scope of who bills those codes and what that would look like.
Thank you.
Yeah. But again, it's a modest investment, particularly with that 90-10 match.
I think I'm still confused and I'm sorry.
That's okay.
If you're asking for Medicaid to increase the reimbursements for what's being termed core family planning services, and then you have in here for family planning providers, does Planned Parenthood of New England have some special, or are you talking about for all providers that bill this code?
That bill this code to Medicaid, yeah.
Okay, so it would be an investment of $85,000 for Planned Parenthood,
Exactly.
but it would affect a full range of providers.
Exactly. And that is not math that I could calculate for you all because I don't have access to Diva's system, which can show you how frequently these codes are billed, how much they pay out, and what that increase would look like.
Thank you.
Yeah. Our second ask is related to the creation of a state family planning program. So PPNNE currently receives $760,000 annually in federal Title X funds. And we attempt We expect that this year there will be another attempt to institute a gag rule on Title X funds, which is the nation's family planning program, similar to the one we saw under the previous Trump administration. Title X is what guarantees patients with low incomes have access to basic preventative reproductive health care. And so losing Title X funding would add to our funding gap and would harm patients' ability to receive care at a sliding fee discount. And so we are asking for the state to develop its own family planning program for low-income Vermonters using that same structure and guidelines we currently follow under Title X, but with a state investment so that the Vermonters' ability to access this care is no longer subject to changing federal administrative rules. And then finally, while this is not a budget ask and carries no state appropriation, we do hope that this committee will take up and pass H214 to establish a safe harbor fund. And this would be for patients seeking abortion care in Vermont. These patients can often face financial barriers related to that care, whether it's travel, lodging, childcare, lost wages, and those costs. So this would be a fund that would help pay for those collateral costs for patients, which is something that we at PPN&E are already providing for patients, and this would be managed by the treasurer's office. So again, there's no state appropriation to it, but it is a bill y'all have on your wall that would help in the broad scheme of patients being able to afford reproductive care.
Where do the funds for this come from then? Did I miss that? I'm sorry.
It is going to be a private donation fund to
Donation.
start with the option for state investment down the road, but they're not asking for a state appropriation this year.
Okay.
This is the 760,000 that's private funded? Is that what I?
No, this is a separate,
Separate fund.
yeah, so this is
Safe harbor.
a safe harbor fund that the treasurer's office is hoping to establish for collateral costs related to care.
Is the state treasurer planning asking for funds? Or are they using some of their existing funds that they have?
My understanding is that not at this time, they're asking for state funds, that it's going to be managed by the treasurer's office, but donor supported fund. But I'm sure they would love to come and talk to you all about it.
All right, if they do, noted that you support it,
Yes.
okay?
Yeah, it's just another way that doesn't have an impact on budget, but could really support our patient access to this care. So I really tried to give you all modest asks and asks with no appropriations in ways that would help us keep our doors open, but recognizing the enormity of the task that you have in front of you with our healthcare system.
Third. Looking up on that one.
Yeah, one question. On the Safe Harbor Fund. Would the service be open to everybody? Not just Vermonters, would be everything?
That's my understanding, yeah.
I think, Brian, did you have a question?
Yeah, it's about this topic right before us, the Safe Harbor Fund, I think you just called it. I'm trying to understand why we need to do something, like, because there's people already raising money for many causes and the committee doesn't have to approve it. Is it because the treasurer doesn't have the power without legislative action to establish a fund like this?
I believe that would be a question for the treasurer's office.
Okay.
They are the ones that are spearheading it. And as it's a service we already provide, this would allow us to seek reimbursement for that service we're already providing. So it is yet another way in which we could shore up our financial status.
Okay, so what I'm hearing is you support it because it's an action that would allow you to continue existing services to people in the face of potential barriers, but you don't necessarily understand the reason why it's coming to the committee, and the treasurer can explain that.
Yeah, I think the treasurer's office would be much better equipped to explain the details.
All right, I appreciate that. And I think I will save any other questions about it for when we have that testimony. Thank you.
Thank you. Any other questions?
Thank you.
Thanks for coming in. And next we have Lauren Hibbert, our Deputy Secretary of State.
Good afternoon. Thank you so much for having me in today. And I am Lauren Hibbert, Deputy Secretary of State for the record. And I really appreciate your time. I wanted to come talk to this committee about the mental health study that we filed in December. I did provide a copy. It should be underneath my name in testimony. And specifically, as a result of that study, we're asking for an executive officer to be created at the Office of Professional Regulation. For background, there's 17 different mental health licenses that are within the Secretary of State's Office of Professional Regulation. And in our mental health study, we really found that there's several ways that we can improve how we are doing licensure there. So at a very high level, we found that our professions would benefit from a vertical consolidation, meaning right now they are in silos, and we would like to make a unified mental health board. We already have the Allied Mental Health Board, which holds some of our mental health professions, but not all of them. So we would have a consolidated mental health board with only psychologists being excluded from that board. We also see opportunities to streamline our entry-level qualifications without compromising professional competency requirements. And we think that there should be additional regulations for supervisors that would support the quality and provider interest in providing clinical supervision. Just for background, every mental health profession requires clinical supervision before you get licensed. And then we did find part of the ask from the legislature was to look at if there were barriers to licensure for certain groups. And we did find that there are barriers currently existing, and we have some recommendations on how to improve those barriers. The report has those 4 big buckets of recommendations, but there's 20 specific recommendations. I'm not going to walk through all of them, but I would recommend that you do review the mental health study. It was an 18-month project that conducted by our office. We engaged with multitudes of stakeholders, very diverse group of people, and some really excellent work was done in that study. So I know you guys get a lot of studies, but this is one that's worth reading. But everyone says that about their studies. So. I have some other ones you should read too. No, just kidding. But one of the most critical recommendations is the creation of this executive officer. The executive officers, we have 2 of them currently within the Office of Professional Regulation, one in nursing and one in pharmacy. Both of those professions are very similar to mental health in that they are complex. The field of study is constantly changing. And they are some of our largest professions at the Office of Professional Regulation. On the second page of my testimony, you can see that nursing, we're just under 25,000. Pharmacy, we're just over 5,000 licensees. And mental health, when you look at all of the 17 types, we're over 10,000. So this is a critical piece. It's an eighth of OPR's licensing body on whole. We license about 80,000 people. Mental health comprises 10,000. Executive officers do a whole lot of things within the Office of Professional Regulation, but one of the things that this executive officer would do almost immediately is help with the consolidation and restructuring of how we do mental health licensure in our state. The Office of Professional Regulation did not come to this body with the statutory language revising all the mental health statutes this session. That is because we just filed that report in December of this year. We recognize that this is going to take some work with our regulated community. This is going to take significant statutory revision. This is pretty much a strike and rewrite of all of our mental health statutes. And then after we do that, it's going to require significant rule revision because all of our current administrative rules are specific to a specific field of study and a specific set of statutes. So as we're changing those things, the rules are also going to be changing. So we were not prepared to do this work in this session. And our hope and intention is to get ourselves prepared to bring a statutory package to this body next session, in this biennium, but next session, so that we can talk about this comprehensively. So that would be the most immediate task for the executive officer. This would require additional stakeholder engagement, a lot of outreach, and then some real legislative policy work creating this new board. Then the position would then spend, after that work was done, and probably while that work was going, would spend significant time reviewing applicants' education. Currently, some of our boards are the only people who review the applicants' education, or the Board of Allied Mental Health employs a third-party contractor to review applications. This introduces a significant delay. Boards meet only once a month. The third-party contractor provides a report to the board makes a determination. Our proposal would be that this executive officer would have, in consultation and communication with the board, the authority to approve applications in between that monthly schedule. We really can't bring these boards together more than once a month. They're licensed professionals who need to work, but also the fact that they're reviewing the applications means that our applications in this profession are delayed. We study how fast our application times are. In nursing, our application times are generally 45 minutes. In mental health, after the person has completed all of the requirements, meaning the exam and the supervised practice, our application times are usually at 45 to 60 days. So this is a place where we could really be more efficient. We would also be able to use this executive officer to help us with ongoing regulatory changes. You know, this is a space where the field is changing and adapting, and we want someone who is specialized in this policy work, someone who has been trained in this policy, someone who specializes in this policy, someone who can communicate effectively with the regulated community, to help us know which statutes need to be modified, which rules need to be modified, where we might need to issue a policy, and where we could be more effective communicating on our website. So that would be another core focus. And then part of the mental health study is working on remedial coursework pathways so that we can get more people licensed. Right now, the rules and the statutes are fairly black and white. And that was one of the core barriers that the study found, which is those black and white barriers are creating hurdles for someone who didn't get educated in the way that the statutes and rules prescribe. And we would like to be able to create alternative pathways or remedial work that someone could do so that the degree that they obtained still has value, but they may need to do additional coursework so that they can become licensed. And that's really important. I don't think I need to tell this committee, we need more mental health licensed folks in this state. We absolutely do. We have really long wait lists, and it's very hard to get mental health treatment in almost every area of the state. So we're trying to be creative. We're trying to be responsive. We're trying to be more efficient, but we do need an executive officer to do that. We are putting that ask in the OPR bill, which is currently down in House Government Operations. We are asking for a general fund allocation for $170,000, which is the cost of salary and benefits. And we're asking for this to come out of the general fund for this year. We anticipate that we will be able to cover this in the OPR budget next year. But this is a recommendation that came after we prepared the budget for FY26. So that's one core reason. But the other is the OPR budget has been running at a deficit, continues to run at a deficit. We're currently at a deficit of about 1.5 million. So we would like to have this position out of the general fund for this year so that we can stand it up, not incur more of a deficit. And we are projecting that we'll be at a slightly less, still at a deficit, but slightly less deficit for next fiscal year. So we would cover this position in our OPR budget next year.
Any questions? Upper?
$176,000. You said this is for salary and benefits.
Yes.
Is that? What about desk and
Yeah.
computer and all that kind of stuff?
Yeah, those are de minimis in comparison, so the office could cover those. But yes, 170 is for salary and benefits. The majority of our team is a hybrid team, so we don't have a dedicated workspace for the majority of our team. And a computer we can absorb in the OPR budget.
Right.
Leslie, go ahead and then Alan.
Jeremy, okay, you said that the bill is now in GovOps.
It is.
So it's gonna be part of our recommend or their recommend?
I'm asking that both committees support it.
And how many people you have on your team?
We currently have 41 on the Office of Professional Regulation. And for those of you who are new, there's some folks that I don't know as well. So nice to meet you. The Office of Professional Regulation regulates 53 professions, and we handle the qualifications and licensure of those 53 professions. Plus, we receive complaints about unprofessional conduct. We investigate those complaints, we prosecute those complaints, and we take action against somebody's license so that they cannot practice any longer or can practice with conditions on their license. And all of those actions are public. So that's very high level who the Office of Professional Regulation is.
I am assuming, and this is only because every time we do like a compact, you come in and talk about fees.
Yes.
I'm assuming analysis is done based upon the profession and how much it costs your office to license someone.
That's an excellent point.
So I'm wondering, would we see savings in the future on the, cost to process a mental health profession license
You can't.
if we have an executive
either.
director? I'm sorry.
You can't read it. Yeah. Oh, true.
So you bring up something that I do want to talk about, which is we have filed an interim money report on the Office of Professional Regulation as well. We are not recommending this session any fee increases, and we are not recommending any major restructuring of the Office of Professional Regulation, because when we started to dig into that report request, what we realized was we did not have enough data where we were tracking how much any particular staff member was spending on any particular profession. So we have implemented, starting at the end of December of this year, something called positive reporting, where our team is reporting by profession code within the timesheet system, the vision system. So we will know how much of our staff is dedicated in a particular week, month, year to clinical mental health counselors. And I do think that this position will take some of the work, will take all of the work away from the third-party contractor, which is a good thing, and will speed up our licensing times. I do think it will reduce the number of hours on whole that is spent on mental health licensing, but that's a complete hypothesis in full transparency, because we're just getting the data on how much time we spend on mental health licensing, and then we'll hopefully add this position, and then we'll be able to do some comparison, although limited, on whether it causes a reduction of time.
Oh, Brian, yes, go ahead.
Thank you. I don't want to take too much time up, but when you were talking about the amount of professions you regulate, because we've worked together for years now, so I'm familiar with the office, but it really struck home the scope and the workload that you're handling. And I was just curious if, when you mentioned handling complaints, I'm aware of I feel like I'm aware of the level of licensure kind of workload, because we've talked a lot about that in this committee, but like, I'm curious if you could say a little bit about the burden of complaints, because I'm guessing you get a lot of complaints that actually aren't viable, because that happens in general. People complain and then it's actually not a complaint. They're just mad about something that's not wrong. But I'm just curious if you could say a little bit about the workload and where we might get more info publicly, just so you don't have to say too much now.
Sure. Well, first and foremost, we issue an annual report every year. So you can look at the OPR annual report that details how many complaints we receive, how many prosecutions we do. But I'll give you a quick synopsis. Representative, we receive approximately 800 complaints a year. The complaints range from frivolous, as you suspected, somebody doesn't like the way CVS is organized. We don't regulate how CVS displays their commercial goods, and it can be confusing. I agree with them, but we don't regulate that. To really serious sexual misconduct, particularly in the mental health professions, that is a black and white rule. You cannot sleep with somebody who is your client. But we do receive complaints about that every year. We receive complaints about drug diversion from hospital floors. We receive complaints about fraud, mismanagement of funds in our money professions. We receive complaints about dirty tattoo shops and cosmetology shops. I mean, we regulate such a wide range of professions. All of us really cannot go through our lives without touching one of our regulated professions at least once a week, if not more than that. They're the backbone of Vermont's workforce. They're a really important piece of how we deliver services in Vermont. But there are instances of misconduct, and we screen in out of that 800 about 600 complaints, and we prosecute about 150 or 200 a year. We have 6 certified law enforcement officers on staff and 3 civil investigators. We have 2 inspectors that inspect the businesses that we regulate, which is primarily pharmacy, funeral, real estate, cosmetology, tattooing, electrology, and used to be motor vehicle racing, but we're recommending the repeal of motor vehicle racing this year. Those are the places that we inspect. And then we have 4 prosecutors who spend their days prosecuting cases in an administrative hearing in front of our boards or an administrative law officer.
Brian, did you have another question?
Well, yeah, it was based on what was just said. I just wanted to acknowledge that sounds like a lot of work to keep people safe, and to hold people accountable. And I appreciate it. And I appreciate you giving us some detail. And I don't think you'll probably want to answer this right now, but I'm really curious what you meant by repeal of motor vehicle racing.
I can answer it really quickly.
Okay.
We did another report that you're welcome to read about motor vehicle racing. And what we found was that Vermont is only one of 5 states in the nation that regulates motor vehicle racing at all. We are the only one that sets up a statutory structure in the way that we do. We're the only one that is as prescriptive as we are. And the insurance marketplace, because there is so much risk with motor vehicle racing, all of the risks that you can anticipate, proprietors of motor vehicle racetracks need and want insurance to protect themselves. And the insurance marketplace does the work that our office does. So we are duplicative. So what we did is what we call a sunset report. We have a sunrise report and we have a sunset report. Sunrise means we analyze whether, some of you know this so well, but some of you are new, so I'm saying it for the new folks. We analyze before Vermont, it's written into Vermont statutes, and it's a beautiful piece of statutory language. It's in Title 26, Chapter 57, and it says that Vermont should not intrude into the marketplace, meaning should not regulate a profession unless there is necessity to do so because there's public harm. And then if we find that there's public harm, then we need to look at, okay, there's public harm. What level of licensure is necessary to protect the public? And we have 3 different levels of licensure. We have the reverse of that. If there's sunrise, there has to be sunset. And sunset requires us to review how we're regulating a profession, make sure we're regulating it at the appropriate level. And in some ways, the mental health study is a sunset review. We are obviously not recommending deregulation of mental health, but we did a review to make sure that we were doing our job the right way and that we were doing it in the most efficient way. And we found that we were not, with specific recommendations around mental health. We did the same analysis with motor vehicle racing and found that we didn't need to be in the space, which is why we're repealing motor vehicle racing.
Leslie, did you have a question? I want to just caveat for the sake of time, let's hold our questions to this position that they're advocating for rather than general question about OPR.
No, my question was why not psychologists included in this?
Oh, that's a good question.
Yeah.
The psychologists really did not, I mean, we engaged with the psychology board as well. They were part of the conversations. The psychology board really did not want to be consolidated. I think that the requirements for psychology and the standards of practice for psychology are a bit nuanced. And I will say that I don't think that consolidation of them into the mental health board is off the table in the future. They just asked to not be in the first wave. The office agreed to that. But what will happen is we'll work to make sure that if and when it is appropriate to include them, that will be as seamless as possible.
So they'll be continued to be licensed under their own board until this.
Yes. Yes, but this executive officer will oversee psychologists as well.
Oh, good.
It will be for all mental health professions.
Okay, thank you. And congratulations, you're the first witness to use the word de minimis in a. Almost like I wanted balloons to come down.
I wish that balloons did come down. Thank you. If only you would have confused the heck out of me, so.
Thanks, Laura.
I'm gonna step out and borrow her ear. So she's not asking for anything, she just wants us to agree to this 7.
Well, we will put it in our budget recommendations as well to appropriations, whether or not we support it. And it would be something that would be funded, but it would be funded through the OPR bill, which is in government operations.
Okay.
So that bill would still have to go to appropriations with the appropriation in it.
Okay.
And we would, or, yes, go ahead.
Breakfast Club, if you could make a recommendation for it to be a one-time budget item, in which case you would want it in the budget and not the OPR.
Okay.
But that's up to you to make a recommendation, because they're just asking for one-time bridge funding,
Yeah.
She's asking for general fund.
which is why you should ask for the part of budget and not any OPR.
Right.
Okay, so let's talk about that when we do our budget
On the
recommendations,
list.
and that's a great suggestion. And next we have Mark McDonough. You want to come on?
Oh, how's everybody doing?
How you doing?
Very good. Kind of wishing I'm not coming after that. Very articulate and well-spoken testimony. Deputy Secretary of State is very well-spoken. But thank you all so much for giving me the time to speak with you this afternoon. Again, my name is Mark McDonough. I'm a battalion chief with the Burlington Fire Department. And I'm also the vice chair of the Emergency Service Provider Wellness Commission. Not sure if folks are familiar with the existence of this commission or not. It was created back in 2021 by Act 37. We were very appreciative of the support from both the House and the Senate in creating that. Just a quick kind of background for me. I've been a first responder since I turned 18 in 1998. I've been a career firefighter for 19 years. And so as you may imagine, I've been exposed to a significant amount of traumatic incidents, and as all of my colleagues have as well. And mental health is incredibly important to me because I have very personally seen the effects that it can take on people and how it's destroyed some of my colleagues' careers and upended their lives. But on the flip side too, when we see the successful outcomes of positive mental health programs, I've seen folks that are in some incredibly challenging times in their lives come out of it on the other side and still have very successful, most importantly, lives, but also secondly, have been able to come back to work and have very successful careers. A little bit about the commission. We are a 25-person commission. We represent Vermont's law enforcement officers, firefighters, EMS providers, emergency telecommunication providers, correction officers, and ski patrollers. And we are supported by the Vermont Department of Health. We, by the statute, are tasked with identifying and making pre-incident behavioral health training and post-incident support and aid available to all of Vermont's emergency service providers. Screen's not cooperating with me. I apologize. Its focus is to identify the gaps in services and systems of care throughout Vermont's emergency responder community, and to recommend how peer support services and qualified clinicians can be delivered statewide. The goal is to ensure equitable access to programs for all responders, whether they're coming from a large municipal department or a small rural volunteer organization. We know that we still have not met our goal. Many of our small rural agencies have no resources available or very limited resources available. In our report that we submitted to the legislature and to the governor back in the fall of this year, we outlined recommendations that we were hopeful we could take action on in the following year. And I wanted to highlight some of the ones that I think are more appropriate for this committee. There is a workers' compensation law that covers PTSD. It makes it presumptive that if a first responder gets PTSD, it's because of the work that they do. Most first responders in the state of Vermont are covered by this, but not all. Specifically, some of the folks that we represent, such as ski patrollers, are not covered by this. And so we are advocating that this bill is evaluated and amended so that it does cover all first responders in the state of Vermont. Peer support communications and making sure that those communications are protected as confidential. We, and I can speak very personally on this because peer support is my specialty. It's my role on the commission as I'm the representative of peer support. I manage the peer support team in Burlington. The only way peer support is successful is if the person that trusts you knows that what they say to you stays just with you and that you will not share that information with anyone. There is indications that a bill may be forthcoming in this session that would protect those conversations as confidential. And the commission is very supportive of the intent of the bill. I will say very candidly that as it is currently written, we have some significant concerns. We have shared that information, and the desire was to work through that as it goes through committee. But I do want to make sure that I tell everybody so that they can have it in their radar that this bill, the intent of it, we are very supportive of. We just think that there needs to be some change in language to make sure that it's covering these communications correctly and also identifies peer supporters correctly. There's just some things that need to be tweaked in that.
And that bill has not been introduced yet? Is that your understanding?
My understanding is it has not been introduced. To the best of my knowledge, the sponsor was still seeking co-sponsors for that bill.
May I inquire, was it a House bill or a Senate bill?
It was a House bill.
Okay,
Yes. Yep.
one less body to track.
Yeah.
Yes.
And sponsor, can you share that?
Stephanie, do you recall the sponsor's name?
We can get that information.
Yes. Off the top of my head, I'm sorry, I don't have it, and I should have. I apologize. But I will make sure to get that, and I can just email that information to Kristen.
Yes.
Is that appropriate?
Right.
I will make sure to do that. Yeah. And probably the more appropriate things for this meeting and committee today is the financial aspect of what we're looking for and requesting in our report. And I'll start right with the biggest thing. So as I said, peer support is absolutely critical to the mental health of first responders, and having those sympathetic and empathetic ears for people to lean on in their times of need. Oftentimes it's because of a traumatic event, but also it's just because of the stressors of life. And we need to make sure that every first responder in Vermont has access to those peer supporters. Currently, we do have a system in place that has been proven very successful. In fact, we're having a debriefing tonight for a local rural fire department that had a fatal fire. You may have seen in the news the other day, a fatal car fire. And it's really critical that these folks have this resource available. It is currently funded through federal grants. And we do not have any confidence that those federal grants will continue to be available and that we can confidently continue to fund this program. So we are asking for funding $160,000 that would provide the funding needed to staff the mental health counselors that are part of the organization, stipends for the peer support team members that travel all over the state to support people in their times of need, and the training costs associated with the monthly group meetings and trainings that we have so that folks stay competent and current in the work.
How many people are we talking about?
On the team?
$60,000.
So $160,000 supports 79 team members that are all over the state and 4 clinicians.
Not full-time clinicians.
I can speak specifically to one because I work with her directly. She works 2.5 days a week for Secure, and then 2.5 days a week private practice.
These staff members all over the state, are they through the fire departments of other communities?
So the peer supporters represent all the different first response agencies in the state. So we have ski patrollers, EMS providers, firefighters, police officers, dispatchers. Yeah. And that program, it's called Secure, is housed through EAP First, which is an agency that is underneath Investia, which is the largest EAP program or company in the state of Vermont. And EAP First is specifically just for first responders.
I'm sorry, really quickly, EAP is an acronym for?
Employee Assistance Program.
Okay, thank you.
Yeah. The next funding that we have asked for in our report is training, money for training, so that we can host multiple trainings all over the state. We're asking for $50,000. We're estimating that will allow us to host at least 5 different trainings that will provide first responders opportunities to stay current in the resources that are available, best practices, wellness, and things like that. And again, this is back to the equity component of things. We know that the large scale organizations have robust programs where they have these trainings all the time as part of their routine. But these small agencies just don't have the financial means or the access to these. The third one and final one is $10,000, and that is so that we can convene a stakeholder meeting in the fall. The plan of this meeting is to bring together emergency service providers, town officials, elected officials, and other key stakeholders to discuss the ongoing needs and lack of resources available so that we ensure we understand what is not out there for our members and that we can then advocate for bringing, for making sure that they do become available. And then just to give you some some data points specifically about the Secure program and the peer support that they offer to folks. Between October 2023 and September of 2024, the Secure team, as I previously mentioned, have 79 trained mentors and 4 clinicians that provide support to this team. Last year, they executed on 13 critical incident stress debriefings, reaching 133 first responders. And then there were an additional 23 peer referrals to mental health clinicians, which means that about 150 first responders were given access to resources that they otherwise would not have had access to. And we know, just looking at those agencies, that they are all small rural agencies that otherwise would not have these resources available to them.
All right. Thank you for your work and for protecting the folks that provide these really critical services. And wonder if you're aware of the rates of suicidality of folks that encounter, especially on a regular basis, incidents like the other day with the car.
Yeah, I don't have that specific number. Stephanie, do you have that number?
We don't have that number. The research nationally shows that first responders, law enforcement, fire, EMS, et cetera, have higher rates of suicide, worse rates of depression, PTSD, et cetera. Part of the challenge with EMS specifically is the occupation that's listed on a death certificate might not so if I like to retire one day, I die, it says I retired, it doesn't say that I did EMS for 10 years, etc. So it's kind of challenging, but the overall research does suggest that there's worse mental health outcomes. And engaging publication.
Sure, thank you.
Oh, sorry, Stephanie Bush.
Stephanie is a colleague of mine on the commission. And is just here to make sure that I have all the needs taken.
Any other questions? I just want to take the privilege of saying that I asked Mark to come in today. I remember setting up this commission in 2021. A couple of us were, and we talk a lot about oversight and accountability and what legislative intent was. I know what our intent was at that time. And, when we set things up, we intend for them to do what we want them to do. And those things don't happen if we don't fund them. So that's why I wanted to make sure that Mark came for that. Leslie.
Since we talk about lived experience a lot here, house fire, 1987, boats went down, everyone came and saved us. So thank you for the work.
Well, the pleasure, I promise you, is mine, not only in my career, but also as a volunteer member of this commission. It is my passion, and I see the very tangible effects that it has and how it does save people's lives. I just had a colleague come to me the other day and thank me, and it was one of the more moving moments I've had. He was so appreciative of the resources that we have in Burlington and how they were able to really support him in one of his darkest times. And I remember when I gave my testimony, it was in the House Senate committee when we were trying to get this going, but it has to be equitable. It's not fair that just because I'm a Burlington firefighter, we have the financial capabilities. I reside in Warren, right? It was very personal to me when I heard that they had this tragic incident a couple of days ago. And so I'll be there tonight for them to support them and help them make sure that they have everything that they need so that it doesn't cause long-term effects and that they don't quit my local fire department, so that when I'm at work, my family still has folks that answer the 911 call. And that's our concern. If we don't take care of our volunteers in this state, what happens if nobody shows up when we call 911? And I understand, we all understand how tough things are financially right now. but this is something that I feel is just so critical to find the funding for so that we're taking care of the volunteers, which is the vast majority of first responders in the state of Vermont. So
Thank you.
thank you. I very much appreciate this.
Thank you, Mark.
Chief Healthcare Advocate is next.
Good afternoon.
Good afternoon. I'm usually not.
Mike Fisher, healthcare. You know, 10,000 years ago, there was a member of the committee down the hall, Tom Koch, who used to say, like, no one was allowed to say "for the record." And that, like, I still think of him whenever I'm sitting down and I say, "You'll never hear me say for the record." Record. I'll just say my name, Mike Fisher, healthcare advocate. So, hey, thank you for having a few minutes. I'm going to try and be really brief because I know there's other stuff on our plates. First off, the Healthcare Advocates Office has no funding request this year. You gave us a small funding request last year, and we are good this year. We'll probably be back for a small cost of living increase next year, but this year we're good. Nobody's come and said that to you yet.
Whoa, thank you for your time.
Change your mind.
Yeah.
So, but that does give me, I do, in my role of supporting our healthcare system, want to speak about other needs in our healthcare system. And I will start with Bridges to Health. So Bridges to Health is a key partner of ours, reaching and supporting a set of pretty hard to serve Vermonters, making sure they get access to insurance and access to care. And I don't know how many years I have come to support their funding request in this committee. This may be 3 or 4, you know, a repetitive thing. So I want to give you sort of the outline of what I understand there needs to be, and any questions about who they are and what they do, we'll make sure you get the answers from the right people. So my understanding is Bridges is funded through September this year, and that in order to be funded for the whole year, they need an additional $675,000.
Whole year of 25 or whole fiscal year of
Fiscal year.
20 through July of 26.
That's my understanding. So that's a base funding of $900,000, part of which they have pieced together with grants, and so they're funded through September. But I want to make a further request, and this is from me, the healthcare advocate, that it's time to tell Bridges, hey, we don't want you begging and filling out, you know, doing small grants and struggling, spending all your time with many, many small grants. It's time to fund them. And not just with a one-time request, but with a base funding request. And so again, their need for this year is $675,000, a base year of $900,000. And that would still have them struggling, still doing some grant work and chasing grants to fund their whole program. But it would fund the community health worker part of their project. So $900,000 for base funding. Okay, and I have a few other topics I want to mention to you. One of them is adult dental. A couple years ago, there was an effort in this committee to raise adult dental Medicaid reimbursement rates from 50% of Delta Dental to 75% of Delta Dental. And with that was a corresponding raise in the adult dental cap. from $1,000 to $1,500. And we asked at that time for DEVA to come back this year with a report on what it would take to, and that report has been delivered to you, how much that action brought in new Medicaid providers, and how much it would cost to eliminate the adult dental cap.
Can you remind the committee what that means, the cap?
So for children and people who are on Dr. Dinosaur because of pregnancy, they get Medicaid coverage for their dental needs. For adults, they get to spend at the Medicaid rates up to $1,500. And that's it. Their dental needs above that are not covered. And we believe that dental generally and Medicaid dental in particular is just one of those places where it makes sense to invest. It's money well spent. It helps people for 100 reasons, social reasons as well as healthcare reasons. And so I would like to be here saying we should eliminate the adult dental cap. DEVA told us that that would cost between 1.83 million and 5.5 million. That's quite a range. And so we thought, and I have lots of questions about how DEVA determined those numbers and whether I've not had an opportunity to really scrub their process. My main request is that we take a step on improving raising the adult dental cap. Using their methodology, we'd have to get these numbers from them, but using their methodology, if we raise the cap from 1,500 to 2,000, Medicaid assumed that there'd be 1,293 people reaching the cap. And so if we multiplied that by $500 each, that's $646,000. I assume there's a Medicaid match, which would bring that down. So gross needs of $646,000 annually. And again, in order to, don't take my word for it on that number. I think in order to, if the committee wants to take action, we're going to need to get a, and I don't know whether raising it to 2,000 is the right thing or raising it to 2,500 is the right thing, but we should take a step in the right direction. It's my request.
Leslie, did you have a question?
Didn't you recently raise it?
Yes, from 1,000 to 1,500.
That was just in 23.
When we raised the reimbursement rate, so the buying power actually was unchanged because the rates went up. And so we sort of kept people's buying powers the same.
Okay, so we didn't really expand any access.
We may have expanded access some by buying some more providers.
Mm-hmm.
But
What did you say the reimbursement rate was?
we raised it, was it in 23, a few years ago?
I think it was last year's budget, wasn't it?
Last year.
I think it was longer than last year.
I remember I was sitting here at the time.
I feel like Mike's right. I feel like it's 2 years.
A few years, because they couldn't have come back with a report that fast.
That's true.
Yeah, it was like 75% of what Delta, did you say, it was 75?
Up to 75% of Delta.
75%, okay. That was in the miscellaneous Vigo bill.
Woody, did you have a question?
Yes. We had talked some time ago about
Mhm.
dentures. With this $2,000 cap, would that cover?
No.
Or is that something separate?
That would be separate.
And I can't remember what the cost for dentures would be, the average cost.
I don't know. It's a big topic.
I think it was the free and referral clinics that came in and talked to us about that recently. Yeah.
Okay, I'm going to keep moving along. We continue, the HCA has always believed, but we're coming today to say, sort of call out. I think it's ridiculous that we don't draw down every dollar of dish that is available to us. We currently draw down $22.7 million. And I'm understanding that there is a short-term cap on dish funding, and that the cost of maximizing our dish drawdown this year is an additional $2.64 million of general fund.
Can you also refresh the committee on DISH?
Dish is federal funding. I think Devin might be able to help, but Dish is federal funding that is in recognition of uninsured and Medicaid populations.
Stands for disproportionate
Share. I think I asked Nolan that my first time I was in committee.
Can you give us those numbers again?
It would cost an additional 2.64 million of general fund.
Okay.
And what that would draw down, I think you'd have get your joint fiscal.
6.4 million gross.
Okay.
I've been in here in past years saying, let's maximize the federal funding, and this is just another one of those.
To go spend money to get money.
Yeah. Quickly, I want to echo what was said this morning, just support the efforts to support primary care. That the Medical Society, I think, was who was in the seat who spoke about it. I have a very low, I don't believe there's a likelihood that we will move to a head in 27. Any federal program that has the word equity as a part of its title, I think has got tough sledding in this administration. So I don't think it's one-time funding. I think it's ongoing need, but I also understand the framing of it as one time for this year, given on paper, we're supposed to move to a head. I also want to mention, as a part of the birthing center discussion downstairs, this is maybe as much as anything a heads up. As a part of the birthing center discussion downstairs, there's been some discussion about the need to increase Medicaid reimbursement rates for labor and delivery. Because that is it's a relatively small number, depending on how much the rates were raised. We think there could be some room to improve Medicaid support for labor and delivery without costing.
We're talking about facility fees for labor and delivery, not.
Madam Chair, I am not sure.
Okay.
I'm thinking Devin Green, Vermont Association of Hospitals and Health Systems, this would be an increase in Medicaid for all. I will have to go back and check. I think we're thinking professional services because it would apply to the freestanding birthing centers as well.
Okay.
And lastly, I am happy that the governor's recommend funds the part of SASH that was paid for by Medicare as part of the all-payer model. But I have believed for a long time that there's some low-hanging fruit in our system, that instead of spending so much money on these payment reform models, we should be just buying the care we know works. And SASH is the prime example of that to me, bringing care coordination to people where they are. This is the old social work part of me, but also that, I think that there's plenty of evidence that this is good investment. And so it's good that $5 million is put towards that. I think we could tenfold that number. I'm not suggesting that, and still not be serving the number of people who people on Medicare who need care coordination wrapped around them. So I think that is just another aspirational thing. I think we should be funding things like SASH, community nursing projects, things that bring care to people in the community.
You're not advocating this year for an increase from 145 to 150 of MSP Quincy? Not that I'm leading the witness, but.
The committee was doing a good job of leading that effort. Yes, the issue that came up the other day in questioning of DIVA staff about the workflow challenges with having Quimby set at 1:45 makes perfect sense to us. It will save efforts on the part of state employees. It'll make the workflow work better. It doesn't cost a ton of money. And by the way, it'll serve a bunch of Vermonters who need care.
So what's it now?
It is to go to 1:45 in January of 26. With action of this committee, it could go to 1:50,
And now it's.
100.
Thank you.
Thank you.
And
Before we go off, can I make an announcement? It'll take like
Yes.
1 minute. I just want to let the committee and anyone who's listening that the Public Health Caucus is having a meeting on Friday, 221, room 10 at 12 p.m. And our commissioner, Dr. Mark Levine, is going to talk about the role of federal agencies play in enabling the work of the Vermont Department of Health. So it's beginning that conversation of feds, us, how are we going to work it out with our commissioner.